Welcome to the episode Quality Improvement Program, a value-based Medicare incentive payment opportunity for Maryland practitioners, brought to you by the Maryland Health Services Cost Review Commission, CRISP, and MedChi, the Maryland State Medical Society. I'm Olivia Simon, the EQIP Practice Transformation Specialist at MedChi, and I have with me today Crystal Fort, Program Analyst at CRISP.
Hi, Olivia. Thanks for having me today. I'm excited to share more information about EQIP.
All right, let's begin with the purpose of EQIP. Maryland's total cost of care model was created to reduce costs and improve quality in hospital and non-hospital settings. However, CMS excludes Maryland practitioners from participating in certain Center for Medicare and Medicaid innovation models. Therefore, the state was given an opportunity to create new value-based reimbursement programs to ensure every Maryland practitioner has access to value-based care and advanced payment models. EQIP was the first specialist-focused program designed to achieve cost and quality savings, both in and out of hospital settings. Before we move forward, I would like to define what we mean when we refer to EQIP as a value-based payment model. There are three main outcomes that define better value. The first outcome is better quality while costs remain the same. The second outcome would be keeping quality at the same level while decreasing costs. And the third and most ideal outcome is to increase quality and decrease costs. EQIP was designed to meet this best outcome. EQIP was created by the Maryland Health Services Cost Review Commission in 2022. The main goal was to have practitioners focus more on outcomes and quality of care for the patient and less on volume. The great thing about this program is it was designed for the practitioner to have full ownership, and there is an upside-only risk to participating. The risk is taken at the state level, not at the practitioner level. Another great aspect of EQIP is it is recognized as an advanced alternative payment model, which allows practitioners to decide if they want to opt out of MIPS. EQIP episode costs include Medicare Parts A and B spending that the Patient-Centered Episode System, or PACES, defines as relevant to the specific type of clinical episode category. Performance Year 4, or calendar year 2025, will include episodes for the specialties including allergy, behavioral health, cardiology, dermatology, gastroenterology, ophthalmology, orthopedics, pulmonary and critical care, rheumatology, urology, and emergency department. Practitioners will have an annual opportunity to enroll in EQIP. The enrollment period will be open July through August of each year before the performance year. For Performance Year 4, or calendar year 2025, enrollment will be open from July 15th, 2024 to August 30th, 2024. The entities who earn savings can anticipate payment in the third quarter. Across the nation, bundled payments have proven effective to help control costs and improve quality. Historically, CMS has shown a 4 to 6% reduction in Medicare spending through their bundled payment programs, which is why EQIP was designed this way. There are three main elements of the EQIP program. First, practitioners agree to an episodic-based payment. Then, using the baseline period, the cost for that episode will be calculated to identify an appropriate target price. Finally, that target price will be used to assess performance. The performance year costs are compared to the set target price to identify if savings were achieved and if participants are eligible for incentives. Our goal is to keep the payment methodology very straightforward so practitioners can monitor their performance and track their success in the program.
Now I'm going to discuss the design of the EQIP program. I would like to start by defining the roles within the program. First, you will hear me refer to a CRP entity, or Care Redesign Program Entity. This is one Maryland hospital that signs a standard contract or agreement with any eligible practitioner in the state that wishes to participate. The CRP entity is what the state uses as an administrative function to be able to pay out incentive payments to the participants in the program. This was a key element in meeting the requirements of a care redesign program. The EQIP entity is the main participation function of the program. An EQIP entity can be an individual care partner or it can be multiple care partners. For example, it can be a single provider practice or two hospital employee practices or a subset of a practice. Ultimately, it can be any grouping a practitioner wants to participate in as an aggregate. It is very important to recognize that performance will be evaluated at the EQIP entity level. Additionally, the EQIP entity will receive a lump sum incentive payment based on the aggregate performance at the EQIP entity level. Next, we have care partners or a specialty practitioner. These are the clinicians who are practicing medicine and performing care interventions. Each care partner will be required to sign a standardized arrangement with that CRP entity. Care partners will receive their normal fee-for-service payments for Medicare, but there is now a potential for incentive payment on top of their traditional billing process. Additionally, care partners who participate in EQIP will be eligible to achieve quality payment program status and bonuses. This is the percent bonus and exclusion from MIPS for participating in EQIP. Last, we have the HSCRC and CRISP, who are the main policy drivers and the ones who will calculate episodes, monitor performance, and determine incentive payments. The HSCRC and CRISP will also be maintaining most of the monitoring and reporting requirements to CMS for participants, which reduces the reporting burden for the EQIP entities. The final role I would like to mention is the administrative proxy. This is a support role for an EQIP entity so they can delegate the management of their program administration how they best see fit. This could be a practice manager or an external consultant or whoever the entities would like to engage to help them manage participation and monitor performance in the program. So let's talk more about the CRP entity. The one hospital chosen to be the CRP entity for Performance Year 4 is the University of Maryland Medical Center. This partnership has enabled EQIP to be recognized as an advanced alternative payment model with CMS. While UMMC was selected, any qualifying practitioner in Maryland is eligible to participate regarding any prior or current relationships or even their privileged status at UMMC. Essentially, a practitioner could have never even touched the UMMC system and still be eligible to participate in this program. The CRP entity, or UMMC, has two main roles. First, they will receive a list of care partners who choose to participate in EQIP and generate a standard contract, or the care partner arrangement that I have previously mentioned. Second, they are responsible for distributing the checks or earned incentive payments. UMC will not calculate these payments. The HSCRC will calculate this and essentially tell the UMMC the amounts to pay each entity. Now, let's look at the requirements for participation. There are three main components. First is that all physicians must qualify as a care partner with Medicare. This means that all practitioners must be up to date in the PICO system, or the Provider Enrollment Chain and Ownership System. This is a crucial part of the CMS vetting process. Practitioners not up to date in PICOS will not pass CMS vetting and will be ineligible to participate in the performance year. Additionally, we require that care partners use CERT, a certified EHR technology, and CRISP, Maryland's Health Information Exchange. The second component is the enrollment requirements. This begins with defining your entity. Practitioners must determine if they are enrolling in EQIP as an individual or with multiple care partners. From there, the entity will select the episodes and interventions they wish to participate in and agree to the quality metrics. Then they sign care partner arrangements, which is the standard contract with the CRP entity. Finally, the EQIP entity will determine where the payment will be sent. Keep in mind, this payment must be sent to one single source across all care partners in an EQIP entity. The final component of the participation requirements is to meet the episode thresholds. The thresholds are determined by Maryland Medicare beneficiaries. For a single episode, the HSCRC requires a minimum of 11 episodes in that baseline period. So for one single episode, an entity must have at least 11 episodes in the calendar year 2019 across all their care partners. In total, an entity must have at least 50 episodes in the baseline. For example, if an entity selects 4 different episodes, each of those 4 episodes must have a count above 11. And when looking at the quantity of all 4 of those episodes, there must be at least 50 episodes total. In the enrollment section, I mentioned intervention selection. The EQIP entity must select what interventions and performance improvement opportunities they will implement to achieve their program goals of improved quality and cost reduction. EQIP entities may implement a range of activities and processes that typically fall into three main categories. The first is clinical care redesign and quality improvement. The second is beneficiary/caregiver engagement. And the third category is care coordination and care transitions. Now, clinical care redesign and quality improvement means implementing new evidence-based protocols in their practice. For example, a discharge planning protocol could be used to facilitate a selection of the most appropriate post-acute setting. This could mean implementing a standardized process for a practitioner to follow up or even providing a discharge summary with a primary care provider. The second category, beneficiary/caregiver engagement, is all about implementing increased shared decision making. Some examples of this would include education provided pre-surgery to a patient and the family caregivers to address post-acute expectations and the management of the recovery. This could also be an in-home assessment that is conducted pre-surgery to assess and address barriers and make referrals if they are needed. The last category is care coordination and care transitions. This could be a care manager that is assigned to follow a patient across the setting and helps coordinate health visits or connect them with the appropriate community resources. It could also be an interdisciplinary team that is set in place to discuss the patient's needs and progress. Ultimately, the EQIP program is site neutral, so selecting the most cost efficient and high quality care setting is a performance improvement opportunity. This could mean shifting from a more expensive hospital unit to a hospital outpatient unit or an ASC, which would help manage a patient's acuity while saving on costs. EQIP is really for all Maryland practitioners, both general and specialists. Here you can see a list of all the episodes available through EQIP for this upcoming performance year. While these episodes are central to the following specialties, there is no limitation to the type of specialist who wishes to enroll and equip under one of these episodes. I would encourage all practitioners to learn more about this opportunity. If you are not sure where you fit into this, you can reach out and we would be happy to speak with you.
Now let's go into more detail on the policy and methodology. There are two main parts when looking at the EQIP methodology. The first is the PACES episode definition. This is where episodes are developed and triggers are defined. EQIP will use the relevant cost methodology to build out an episode. Together, this works as the episode builder. The HSCRC does not dictate the policy around the episode builder, but rather the state contracts with a vendor who owns the PACES definitions and algorithm. The second part of the methodology includes the HSCRC and CMS policy. This is where we set parameters around the target price, the shared savings, the quality measures, reporting and monitoring, available specialties each year, and of course, this is the state's policy with CMS, which includes that QP status policy. The Patient-Centered Episodes of Care System, or PACES, was incorporated in 2019 to further update and enhance earlier groupers developed for CMS. PACES is fully committed to developing a clinically sound episode grouper in collaboration with the clinical community and stakeholders. There are currently 1,090 episodes grouped into clinically relevant areas. They are procedural, chronic conditions, and acute conditions. These episodes can be triggered by a procedure or diagnosis. Each episode has a look-back window and a closed period window. Both periods are configurable based off that episode. The look-back window is typically 30 days, and this is the period set to capture any pre-surgical care. For example, radiology, labs, or any other workups that may be done. The closed period window then follows that beneficiary for a set period and counts the relative costs. For our Performance Year 4 episodes, that closed period window ranges from 14 to 180 days. The PACES model will comb through all the claims and aggregate them into episodes to determine what the relevant episode costs are. Analysis across the continuum identifies opportunities for cost savings, quality improvement, and potentially even some referral guidance. Now we are moving into the second part of the EQIP methodology, which includes the HSCRC and CMS policy. This is the state methodology used to determine if an incentive payment should be earned. First, we need to set a target price based on the episode. To do this, we get a cost for the baseline. In performance year 1, we use the 2019 year as the baseline, and we have kept this as the baseline year for the first 3 performance years. Each EQIP entity will be assigned their own target price. To do this, the HSCRC will look at the weighted average cost per episode of the care partners within an EQIP entity and aggregate this to create a unique target price for that EQIP entity. We will then trend the baseline cost forward to make it comparable to the 2025 cost. This allows entities to compare their real-time price to their real-time performance cost. However, we must note that the final target price will not be finalized until the end of the performance year, when final inflation has been applied. It is also important to note that target price is set independent of the care setting. So this means that across all the different settings that a practice may provide these procedures, the episode will keep a single target price. The reason behind this is that we want the cost to follow the practitioner and to be measurable across all of your businesses. Additionally, due to the model, we know there is a large gap in cost between hospital procedures and ASP procedures under our Medicare fee-for-service schedule and compared to commercial payers. So we want to align incentives between practitioners and hospitals to shift lower acuity procedures to lower cost settings when appropriate. Now let's walk through how payment methodology is done. The first step is to assess the performance period results. At the end of the performance year, we will assess the results seen across the episodes in which the EQIP entity is participating. If the aggregate costs across the EQIP entity performance period are less than the target price, we will determine that savings were made. There must be at least 3% of the savings achieved, and this is to ensure that savings are considered statistically significant. The second step is to determine the shared savings. The savings will fall into one of 3 tiers. Using the baseline data, EQIP entities will be compared using the statewide experience and ranked on efficiency. This rank will give us the relative shared savings tier that will be paid out. The higher cost practitioners are ranked in the lower tier, and therefore a lower percentile is shared. Our lower cost practitioners are ranked in a higher percentile with higher shared savings. The lowest ranked tercile has a 50-50 split with the state, and therefore the entities will only receive 50% of the shared savings. For our middle tercile, the state will pay out more savings, acknowledging it is harder to create savings if you are already a relatively efficient practitioner compared to the state. This middle tercile will earn 65% of their savings. And finally, our lowest cost practitioners, those that fall into the top tercile from the start, will be paid the largest percentage of the shared savings, which is 80% of the savings they create. Quality is also a very important component to value-based payment models, which is why the third step is to consider the clinical quality score. To ensure the outcomes of the program are not at the cost of patient outcomes, 5% of the shared savings will be withheld pending assessment on 3 quality metrics. The performance on these quality metrics will determine how much of that 5% is earned back by the entity. And Crystal will talk about this a little bit more. The fourth step before shared savings are paid out is to check on the incentive payment cap. The state must confirm that the calculated payment is no more than 25% of the prior year's Part B payment. Once all the steps 1 through 4 have been completed, the HSCRC will direct the CRP entity to pay the incentive payment to the EQIP entity. This will be paid in full as a lump sum 6 months after the end of the performance year. To clarify, this is just one payment to the EQIP entity, and any distribution at the individual care partner or practitioner level will be left to the EQIP entity and not to the state.
Since that was a lot to walk through, I thought it would be helpful to share an example calculation that may help explain these steps. In this example, this EQIP entity is participating in 2 episodes, and their baseline episodes costs are $15,000 and $10,000 respectively, seen in line A. For the purpose of this example, we are not including inflation, which keeps the target prices also at $15,000 and $10,000. The volume seen during the performance year is multiplied by the cost in the performance years. So line D and C produce the aggregate actual performance year episode cost in line E. Now that we have the aggregate cost, we compare it back to the target price to determine if savings were achieved. In both episodes, in the example, savings were achieved, and they both met the 3% threshold. Now the tier savings rate is applied. For this example, we put the entity in the top tercile during the baseline, and therefore it is due an 80-20 split. When 80% of the shared savings is applied, we get $34,000 as the final incentive payment. Now, since this is just a hypothetical example, I have left the final payment at $34,000. But in real life, the $34,000 would be less pending any quality adjustments and that 25% cap check. In the beginning of this presentation, we mentioned that EQIP was designed to have an upside risk only, but incorporating some savings accountability. This accountability is important to drive meaningful improvements in cost efficiency and quality, but also keep stringent standards for enrollment in the program. Therefore, there is a savings accountability plan. Any entity that creates savings in a performance year will be required to offset those savings in the following performance year prior to earning out any incentive payments. An EQIP entity can also be removed from the program if they are in the lower two terciles, which is less than the 66th percentile, and they have had 2 consecutive years of savings. So let's explain the logic here. Since EQIP is upside only, we want to ensure that practitioners are not only participating for the AAPM status and QPP opportunity, but to also help drive costs down and improve quality. The reason we exclude the top tercile performers is because if an entity is already very efficient during the baseline, it is much harder for them to create savings. During our discussion about the incentive payment calculation, we talked about a percentage of that shared savings being withheld pending performance on quality metrics. Now let's talk about these quality metrics. When selecting these quality metrics, the state thoughtfully chose measures that could be applied effectively at the practitioner level that can be measured off claims and would not be a recording burden for practitioners. The second selection criteria was to align CMS, and therefore we were looking at high priorities and outcome-based measures. CMS also required at least 3 measures to be selected for this program. Lastly, these measures were chosen in conjunction with HSCRC or the state's priorities, which include a parallel design to other payers. This is because we did not want to have different quality metrics applied to different episode selections. We really wanted to encourage participants to select any episodes that they were eligible for. Thirdly, we wanted to align with the state's larger population health strategy, SIHIS, or the statewide integrated health improvement strategy. The 3 quality measures are advanced care planning, documentation of current medications in the medical record, and preventive care and screening around body mass index screening and follow-up plan. These 3 measures will be the same regardless of the practitioner's specialty and regardless of the episodes each EQIP entity chooses to participate in. So again, if an entity chooses to participate in 1 episode or chooses to participate in 15 episodes, for all episodes, these quality metrics will be the same. These measurements are used to calculate the 5% earned back adjustment on the incentive payment calculation. I would like to highlight that for each triggered episode, these measures are assessed, determining if the measures were performed by any practitioner in the 365 days prior to the end of the episode. Therefore, these measures do not need to be performed by the triggering care practitioner, but rather we want to incentivize the coordination across the care continuum with other practitioners who might more frequently provide these services, such as your PCPs. The last part of the quality metrics is to remember that these are based on Part B claims, so it is important to bill for these measures by tracking the appropriate CPT codes for each. The state has developed the EQIP entity portal to support participation in EQIP. The EQIP entity portal is used for enrollment and opportunity analysis, CMS vetting and required activities, CRP entity contracting and operation support, and performance analytics, learning system, and program communications. Access to EAP is a requirement for participation. Ultimately, the 3 main uses of the EQIP entity portal are to enroll participating entities, manage participation, and to view program data. I know I have just covered a lot of information, so I would like to briefly summarize the opportunities and benefits of this program. As mentioned, EQIP is a value-based payment program that the state has tailored to Maryland practitioners. Whether the practitioner is in a private practice or hospital setting, the program was designed to be agnostic to this type of relationship you may have with hospitals or health systems. Instead, it is designed to follow the practitioner and how they practice with their patients. Since Maryland has been precluded from other value-based care models, this is a great opportunity for practitioners, general or specialists, to participate in a model without any downside risk. Next, we see a benefit of system alignment regardless of the care setting. This circles back to the program being beneficial for all types of employment, including both hospital and non-hospital settings, which is unique to this program. The fourth benefit is that these episodes are tailored to the typical practitioner practice patterns and scope of impacts, meaning the costs are tied back to the practitioner and the typical patients they see in their practice. And finally, to cycle back to the fundamental goals of the value-based models, this program contributes to the health system improvement and ultimately drives down costs and improves patient outcomes.
We have mentioned the general timeline for EQIP, but now I want to review the specific timeline for Performance Year 4, or calendar year 2025. Enrollment will open on July 15th, 2024. During this window, the EQIP entity portal will be officially open for enrollment. In addition, the technical policy and portal user guides and baseline episodes will become available. Enrollment will end on Friday, August 30th, 2024. This is the deadline to submit all National Provider Identification, or NPIs, and other enrollment initiation information into the EQIP entity portal. Also at this time, practitioners who have enrolled will be submitted to CMS for vetting and contracting. By December 1st, 2025, all care partner arrangements and payment operations will be finalized. January 1st, 2025 will officially mark the beginning of Performance Year 4. Shortly after, the preliminary target prices will become available in the EQIP entity portal. Performance Year 4 will run until December 31st of 2025. And finally, the incentive payments will be distributed in the fall of 2026. If you would like to schedule a meeting to discuss more about EQIP, please reach out to equip@crisphealth.org. You can also join the EQIP subgroup distribution list to learn more about the most recent EQIP information, news, and opportunities. The subgroup meets bi-monthly on the third Friday of the month. If you are interested in participating in Performance Year 4, please reach out so we can get you started in the enrollment process. And that concludes this presentation. We are really proud of the work we have done on this program, and we'd love for you to be a part of it. Thank you so much for joining us today.